Welcome to another AchieveCE live webinar. In case you're new to AchieveCE, we focus on offering courses on the important trending topics of the day to keep you up to date in your field, while also satisfying your continuing education requirements. Aside from our live webinars, we also offer on-demand text and video courses to take at your convenience, all of which are available in our membership. The last few minutes of this webinar will be dedicated to a live question and answer session with the instructor. Please feel free to enter your questions or comments into the chat during the presentation, and they will be responded to by the instructor at the end. At the end of this webinar, you will need to complete a survey and enter the provided 4-digit code to receive course credit. Once you've completed this course, your credits will be reported to CE Broker and CPE Monitor within 24 hours, and a certificate of completion will be given. With no further ado, I'll go ahead and pass it to today's instructor.
Hello everyone. This presentation is titled From Inflammation to Liberation, Therapies for Rheumatoid Arthritis Relief. My name is Elif Özdener Poyraz, and I will be your speaker today. I have no financial relationships with ineligible companies to disclose. By the end of this lecture, you should be able to describe the pathophysiology of rheumatoid arthritis, or RA, recognize the signs and symptoms of RA, identify the clinical and laboratory diagnostic factors, evaluate various non-pharmacologic and pharmacologic treatment strategies available for RA, and finally, create a treatment monitoring and follow-up plan for patients with RA. I want to start off by first describing the synovial joint diagram. So as you can see, this is a joint capsule of a knee. The ends of the bones are encased in smooth muscle cartilage in the synovial joint. They are protected by the joint capsule, which is lined by a synovial membrane. This membrane produces synovial fluid. The capsule and the fluid protects the cartilage, the muscles, and the connective tissue around the joints. I'm explaining this because rheumatoid arthritis is a chronic autoimmune systemic inflammatory disease that primarily affects synovial joints, and usually it affects the joints symmetrically. So if one knee is involved, the other knee will also be involved with the disease process. Rheumatoid arthritis can also affect other organs, so it can have extra-articular manifestations in organs such as the eyes, heart, and lungs. If left untreated, rheumatoid arthritis can lead to significant deformity and disability in patients, which is why it's very important to treat as soon as the patient is diagnosed with RA. RA tends to affect women more than men. Women are 2 to 3 times at higher risk of being diagnosed with RA compared to their male counterparts. However, there are no racial predilections, meaning that no particular racial subgroup has a higher risk of developing RA compared to another. And the disease is most prevalent between the ages of 15 to 45. What causes the disease process, the synovitis, is really an interplay between genetic and environmental factors. We know that patients with RA have presence of certain genetic factors that predisposes them to developing rheumatoid arthritis. Specifically, HLA-DRB1 alleles have been identified and associated with the development of RA. Cigarette smoking is the strongest environmental factor that has been correlated with RA. Other environmental factors include exposure to silica and asbestos. So combination of genetic predisposition and environmental triggers lead to autoantibodies, specifically RF, which is rheumatoid factor, and anti-citrullinated protein antibodies, or ACPA, causes the development of chronic inflammation of the synovial membrane that lines the joint capsule, leading to synovitis. Cytokines such as tumor necrosis factor, or TNF, as well as interleukin 1 and 6 also play a major role in the development of RA. As you know, cytokines are messenger proteins, and you'll see later on in the presentation that some of the medications that we use to treat rheumatoid arthritis actually work to either block TNF or interleukin. The joints that are most commonly affected in RA are the joints in the hands, wrists, and knees. However, elbows, shoulders, hips, ankles, and feet can also be involved. Patients will oftentimes complain of joint stiffness, and joint stiffness is worst in the morning, and how long the joint stiffness lasts correlates with disease activity. So patients that have joint stiffness for 2 hours, 3 hours in the morning have higher disease activity than those patients that have joint stiffness that lasts less than the 2-3 hours. And in addition to joint stiffness, patients will also complain of pain and tenderness, swelling in the affected joints, weakness in their ability to grip, clasp, or pinch objects, so their fine motor skills will be affected. And if they have, disease processes in their knees, ankles, or feet, they may also complain of difficulty walking. The diagram on the right shows the difference between rheumatoid arthritis and osteoarthritis in how it affects the joint capsule, as well as the difference in symptomology between the two disease states. So you can see a patient with rheumatoid arthritis will have swollen and inflamed synovial membranes, whereas patients with osteoarthritis have loss of articular cartilage in the joint. Rheumatoid arthritis causes erosion of the bone, whereas with osteoarthritis, because of the loss in cartilage, patients will have their bones rub against each other, causing them pain. RA is considered to be an autoimmune disease because we know that there are autoantibodies that are positive in patients with RA, whereas patients with OA, osteoarthritis have degenerative disease. They don't have autoantibody involvement at all in their disease process. The joints that are involved are often asymmetrical, so they may have just one knee or one elbow that is affected by the disease process, whereas patients with rheumatoid arthritis will have symmetrical involvement. So they'll have both elbows or both knees or both ankles that are affected by RA. And in terms of symptomology, patients with rheumatoid arthritis, as I mentioned earlier, will have morning stiffness that lasts oftentimes greater than 30 minutes. And they'll have pain, stiffness, and inflammation, whereas patients with OA will have pain and stiffness with movement, and their morning stiffness usually lasts less than 30 minutes. The diagnosis of rheumatoid arthritis is based on a number of different criteria. It requires the clinician to take an adequate and thorough history of the patient's symptoms, as well as do some lab work to check if the patient has developed autoantibodies and whether they have the presence of inflammatory markers. So diagnostic criteria usually looks at whether the patient has inflammation or inflammatory arthritis involving 3 or more joints, whether they have RF or ACPA autoantibodies, whether they have elevations in acute inflammatory phase reactants such as C-reactive protein or CRP, and or elevations in erythrocyte sedimentation rate, or ESR. Disease RA, disease RA has very similar symptomology, similar signs and symptoms to other types of arthritis, including psoriatic arthritis, lupus, and gout. For that reason, it's important to not just look at the patient's symptoms, but also look at the other markers that are needed to identify rheumatoid arthritis, primarily the autoantibodies that are associated with RA. And then finally, asking the patient for the duration of their symptoms. So this is completely patient reported. If the duration of their symptoms are longer than 6 weeks, it correlates with more established disease compared to patients who have had the symptoms for a much shorter period of time. It's important to note that patients do not have to meet all of the criteria that I mentioned in order to be diagnosed with rheumatoid arthritis. However, if the patient doesn't meet all of the criteria, it is important to exclude other diseases that may be causing the patient's symptoms in order to narrow down the field and really decide whether the patient has rheumatoid arthritis. Once the patient is diagnosed with rheumatoid arthritis, it's really important to understand disease activity and whether the patient has low disease activity, moderate, or high disease activity, because these measurements are going to help us to decide which medications the patient needs to control their disease state. So there are several tools that are available to measure disease activity in patients with RA. I've listed 3 of them here. However, this is not an all-inclusive list. There are other tools that are also available that are recommended by the ACR guidelines. The ones that I have listed are an example of the preferred assessment tools that are recommended by the American College of Rheumatology. The first one is the Clinical Disease Activity Index, or CDAI. Second one is the Disease Activity Score 28. And then finally, the Simplified Disease Activity Index, or SDAI. Based on how the patient answers some of the questions in these tools, they are given a total numeric score, and that numeric score is going to correlate to either the patient being in a state of remission, low disease activity, moderate, or high disease activity. For patients with RA, our goals of therapy are to achieve and maintain remission or low disease activity, prevent deformities caused by RA, improve quality of life, minimize medication-related adverse effects, and finally minimize costs to the patient where we can. It's important to mention here that not every patient with rheumatoid arthritis will be able to reach a state of remission, which is why the guidelines state that low disease activity is also a goal, especially for those patients where remission is not a feasible target for them. So for patients that are able to reach remission, that's great. We want to keep them at remission for as long as we can. However, for those patients where remission is not possible, low disease activity is also an acceptable goal. There are several non-pharmacologic interventions that are recommended in the guidelines. The first one is patient education. Formal education programs through various organizations have been shown to reduce pain, depression, and disability in patients with RA. Also, psychosocial interventions such as cognitive behavioral therapy may show modest improvement in symptoms of fatigue and self-reported pain in patients. Physical activity such as resistance training or aerobic exercise can be part of the patient's treatment plan, and really should be part of the patient's treatment plan in those with RA, because it can reduce disease activity, reduce fatigue, pain, and also improve psychosocial well-being in patients. Rest is only appropriate for patients when they have acutely inflamed joints. In these circumstances, patients may also require splints. However, the guidelines do not recommend regular periods of rest for patients with RA because patients with rheumatoid arthritis also tend to have sedentary lifestyles. So recommending rest to patients may actually exacerbate rheumatoid arthritis instead of helping. Therefore, rest is only really recommended for patients that have really acutely inflamed joints that require splints. Patients may also benefit from physical and occupational therapy, especially if they're showing signs of deformity. Physical and occupational therapy can provide pain relief for patients, reduce inflammation, preserve joint integrity, strengthen joints over time, and maintain range of motion for patients that have more advanced disease. Some general therapeutic principles in the management of RA include initiation of disease-modifying anti-rheumatic drugs or DMARDs as soon as the patient is diagnosed with RA. The reason for this is because we know RA, especially when it's left undertreated or untreated, leads to significant joint damage in patients, and the longer patients do not take DMARDs, the more likely that they will develop disability in the long term. So initiation of DMARDs as soon as it's feasible is recommended for all patients with rheumatoid arthritis. A treat-to-target approach is also strongly recommended for patients who have not previously been treated with biologic or targeted synthetic DMARDs. This is only true if the patient has reached remission or low disease activity and maintained that goal for at least 6 months before they could be eligible for a dose reduction of their medications. So although treat-to-target approach is recommended, it is important to note that patients have to maintain their goal for at least 6 months before they're eligible for any dose reductions. The guidelines also strongly recommend against the use of long-term corticosteroids and conditionally recommends against the use of short-term corticosteroids, even as bridge therapy in patients with rheumatoid arthritis. And the reason for this is because of the many adverse effects associated with this class of medication. Although clinically speaking, we know that corticosteroids are still frequently utilized in patients with RA, especially for those that are newly starting therapy, because DMARDs do not work very quickly, and oftentimes patients are in so much pain and the pain affects their quality of life. Short-term corticosteroids can provide quicker relief for patients while we wait for DMARDs to take effect. Hydroxychloroquine is conditionally recommended as a first-line regimen for patients that are DMARD naive and they have low disease activity at baseline. So these are for patients who are really newly diagnosed with RA, who have low disease activity based on one of the measurement tools that we talked about in the previous slides, and they've never been on disease-modifying anti-rheumatic drugs in the past. For patients who present with moderate to high disease activity at baseline, hydroxychloroquine is not as effective, which is why methotrexate monotherapy is recommended as the first-line option in those patients. And for patients that are, again, newly diagnosed, the initial treatment goal should be low disease activity. This is the preferred target over remission. Because as I mentioned earlier, reaching a state of remission might not be a reasonable target for most patients, especially when they're first starting off on DMARDs, which is why low disease activity should be the initial target. Once a patient reaches low disease activity, if remission is a reasonable, plausible target for that patient, then remission should be targeted next. However, the initial target should always be low disease activity for patients that are newly starting DMARD therapy. This slide here contains a comprehensive list of the DMARDs that are available, and it's divided based on the type of DMARD. So the left-hand column is our oldest DMARDs, conventional synthetic DMARDs. These include medications such as methotrexate, hydroxychloroquine, sulfasalazine, and leflunomide. We also have our biologic DMARDs. These are divided into two subcategories. We have our tumor necrosis factor alpha inhibitor biologics. This includes medications like adalimumab, certolizumab pegol, etanercept, golimumab, and infliximab. We also have our non-TNF alpha inhibitor biologics, including abatacept, tocilizumab, rituximab, sarilumab, and anakinra. Anakinra is actually no longer recommended by the guidelines. And then finally, we have our targeted synthetic DMARDs. These include our JAK inhibitors, which are our Janus kinase inhibitors. So we have 3 medications that are approved for rheumatoid arthritis in this class. This includes tofacitinib, baricitinib, and upadacitinib. As I mentioned earlier, the guidelines really do not recommend corticosteroids across the board for all patients with RA. In fact, for DMARD naive patients that have moderate to high disease activity, initiation of a conventional synthetic DMARD without short-term corticosteroids is conditionally recommended over initiation of CS DMARD with a short-term corticosteroid. So this means that the voting panel of the guidelines no longer recommend bridge therapy for patients that are newly starting DMARD therapy for their rheumatoid arthritis. And the guidelines also state that initiation of a CS DMARD without long-term corticosteroids, so this is defined as using corticosteroids for 3 months or longer. This is actually strongly recommended over starting CS DMARDs without long-term corticosteroids. So you can see here that the guidelines really recommend using CS DMARDs by themselves without corticosteroids, whether it's for short-term or long-term use in patients that are newly starting DMARDs, so they're DMARD naive with moderate to high disease activity at baseline. In terms of DMARD selection, our conventional synthetic DMARD methotrexate is strongly recommended over our other CS DMARDs such as hydroxychloroquine or sulfasalazine and leflunomide. It's actually also recommended, strongly recommended over even biologic DMARDs or targeted synthetic DMARDs because it is a very potent DMARD, and usually it does quite a nice job in bringing patients to goal, especially when they are DMARD naive, can bring them to goal even as monotherapy. Methotrexate monotherapy is also conditionally recommended over dual or triple therapy of a combination of conventional synthetic DMARDs. So what the statement says is that methotrexate monotherapy works better or works sufficiently compared to combining methotrexate with other conventional DMARDs, such as combining it with hydroxychloroquine or sulfasalazine. It's also recommended as monotherapy over combining it with a TNF alpha inhibitor. And finally, methotrexate monotherapy is also strongly recommended over methotrexate plus a non-TNF alpha inhibitor biologic or a targeted synthetic DMARD. For patients that present with low disease activity at baseline who are DMARD naive, hydroxychloroquine is conditionally recommended over other conventional synthetic DMARDs, including methotrexate. This is because hydroxychloroquine may be sufficient in managing the patient's symptoms, and hydroxychloroquine is considered to be more benign, for lack of a better term, in terms of side effects compared to methotrexate. It's associated with less serious side effects compared to methotrexate, which is why hydroxychloroquine has this conditional recommendation over methotrexate and other CSD-MARDs because of its efficacy in this population as well as lesser risk of side effects. Sulfasalazine is also conditionally recommended over methotrexate in this patient population. And finally, methotrexate is conditionally recommended over leflunomide in patients with DMARD naive, low disease activity RA. And again, these preferences are really based on medication potency and also risk of side effects for the patient. The first CSD-MARD we'll talk about is methotrexate, since many patients will start off on methotrexate initially. The starting dose for methotrexate is 7.5 to 15 milligrams once weekly, and providers can titrate up the dose up to 25 milligrams per week based on patient response. As I mentioned earlier, DMARDs do not work very quickly. The onset of action for methotrexate is about 3 to 6 weeks, and patients may see continued improvement even past the 12-week mark. Methotrexate is associated with a lot of side effects. Some common adverse effects include GI ones, such as diarrhea, nausea, vomiting, and oral mucosal ulcers. Patients can have increases in LFTs. They may complain of CNS side effects such as dizziness, fatigue, and headache, and develop a cough. A lot of the side effects, especially the common ones associated with methotrexate, is thought to be due to its mechanism of action, which is to deplete folic acid, and the side effects are thought to be related to folic acid depletion. So co-administration of folic acid at 1 milligram once daily or 5 milligrams once weekly is recommended. It's not recommended to wait for patients to develop these side effects. Folic acid should be co-administered with methotrexate from day one. So folic acid supplementation is recommended for those patients that will be on methotrexate. Some serious side effects of methotrexate include interstitial pneumonitis, which is reported with even low-dose methotrexate. Patients can also have bone marrow suppression, infections. They could have nephrotoxicity or hepatotoxicity, as well as hypersensitivity and dermatologic reactions. There are also several contraindications to methotrexate, including pregnancy and breastfeeding, alcohol use disorder, alcoholic liver disease, or chronic liver disease. This is really due to the risk for hepatotoxicity with methotrexate. If the patient has other comorbid conditions such as alcohol use disorder, that may increase the risk of hepatotoxicity. Obviously, it would be a contraindication to this medication. Additional contraindications include immunodeficiency as well as blood dyscrasia such as leukopenia or thrombocytopenia. It is recommended to monitor serum creatinine, CBC with differential, AST and ALT at baseline, as well as every 2 to 4 weeks for the first 3 months of therapy, followed by every 8 to 12 weeks for the next 3 to 6 months of therapy. And if the patient continues to have normal levels, the monitoring can be stretched out to every 12 weeks, every 6 months of using methotrexate. Hydroxychloroquine is better tolerated than other CSD-MARDs. It is not associated with myelosuppression, with hepatotoxicity or nephrotoxicity, as is methotrexate, which is why it is preferred in patients that have low disease activity who are DMARD naive. Its onset of action is approximately 6 weeks. One of the most prominent, well-known adverse effects of hydroxychloroquine is retinopathy. This is a rare adverse effect of hydroxychloroquine. However, it can lead to blindness, irreversible damage to patients. Although patients that are caught early on, the damage might be reversible. However, if it's caught later, even with discontinuation of hydroxychloroquine, patients will have retinopathy. There are certain risk factors that a patient may have that may put them at higher risk of hydroxychloroquine caused retinopathy. These risk factors include using a hydroxychloroquine dose that is 5 milligrams per kilogram or greater of actual body weight, and duration of therapy that is longer than 5 years, having higher serum concentrations of hydroxychloroquine, having pre-existing macular disease, lower body weight, kidney impairment, or concurrent tamoxifen use. Although hydroxychloroquine has milder adverse effects compared to methotrexate, this is a serious side effect of this medication, and patients should be warned about it ahead of time. And patients should have a comprehensive vision exam, an eye exam prior to initiating hydroxychloroquine, and if everything is normal at baseline, they should have it repeated at least at the 5-year mark to make sure that they don't have any retinopathy. Sulfasalazine is another conventional synthetic DMARD that is not used as frequently as methotrexate or hydroxychloroquine. And the reason for this is because of its many side effects. This medication also has a few notable drug interactions that pharmacists should be aware of. I'm not going to go through all of the common adverse effects associated with sulfasalazine, but it is important to note that it has a lot of GI, dermatologic, hematologic, hepatic, CNS, as well as genitourinary side effects. Something that patients may notice after starting sulfasalazine therapy is the change in their urine and skin color, which changes to a yellowish, orangish hue. So this is an important counseling point for patients that are starting sulfasalazine for the first time. This medication does interact with antibiotics because of reduced absorption of sulfasalazine. Also, iron supplements tend to bind to sulfasalazine, and it is expected to increase INR in patients that are using warfarin. Onset of action of this drug is a little bit longer than hydroxychloroquine. Patients should expect to see improvement in symptoms in about 2 months. And monitoring recommendations include serum creatinine, CBC with a differential, AST/ALT at baseline, followed by every 2 to 4 weeks for the first 3 months of therapy. Then the monitoring can be stretched out to every 8 to 12 weeks during the 3 to 6 month mark. And then finally, if everything remains normal, it can be further stretched to every 12 weeks after the 6-month mark. The last CSD-MARD we will talk about is leflunomide. Just like sulfasalazine, leflunomide is also associated with many adverse effects, the most notable of which is severe liver injury, which is why this medication is contraindicated in patients that have severe hepatic impairment. It's also not recommended with anyone who has acute or chronic liver disease or ALT levels that are greater than 2 times the upper limit of normal at baseline. Leflunomide can also cause fetal harm, which is why it's contraindicated with pregnancy. It's required that patients undergo a pregnancy test prior to initiating leflunomide. And leflunomide must be discontinued if the patient did not use adequate contraception or their contraceptive failed and they became pregnant. Next, we'll talk about guideline recommendations for patients that are DMARD experienced. So these are patients who are likely already taking a CS-DMARD, such as methotrexate, who are unable to reach their target of low disease activity or remission. So the guidelines recommend in these patients to add either a biologic DMARD or a targeted synthetic DMARD over creating a triple therapy regimen with 3 conventional synthetic DMARDs, such as adding hydroxychloroquine and sulfasalazine to methotrexate. The reason for this is because adding a biologic or a targeted synthetic DMARD to methotrexate will be more effective in making sure the patient reaches their target over adding 2 conventional synthetic DMARDs to the already existing methotrexate therapy. For patients who are already on a biologic or a JAK inhibitor, it is recommended, and they don't respond to whichever biologic or targeted synthetic therapy they're on. It's recommended in those patients to switch to a different class altogether, as opposed to switching to a different medication within the same class. So for example, if the patient is on a TNF-alpha inhibitor, such as adalimumab, it is recommended to switch the patient off of adalimumab to either a non-TNF biologic or a JAK inhibitor, as opposed to switching to another TNF-alpha inhibitor. We also have our non-TNF-alpha inhibitors, which include abatacept, which is a T-cell co-stimulation inhibitor. We have rituximab, which is a CD20 inhibitor, and we have 2 additional monoclonal antibodies, tocilizumab and sarilumab, which are interleukin-6 inhibitors. For this umbrella of medications called non-TNF-alpha inhibitors, it is recommended to still screen for latent TB as well as hepatitis prior to initiation. For abatacept, which is available both intravenously and as a sub-Q injection, caution should be used in patients that have baseline COPD, as there are reports that this medication can cause COPD exacerbations. Also, this medication is associated with skin cancer, so periodic skin exams are recommended in case the patient does develop malignancy while they're on abatacept. We also have IV rituximab. This medication must be pre-medicated with acetaminophen, antihistamine, and methylprednisolone, 100 milligrams IV, 30 minutes before infusion, because it is associated with many infusion reactions. Rituximab is recommended really for patients who are not at goal despite maximally tolerated methotrexate and inadequate response to another TNF-alpha inhibitor. The reason why this is not one of the preferred biologics is because of the many serious side effects associated with it, not only infusion reactions, but also progressive multifocal leukoencephalopathy, severe mucocutaneous reactions, severe infusion reactions that can occur with rituximab. Some common side effects with this drug include flushing, hypertension, peripheral edema, rash, weight gain, abdominal pain, antibody development, and many, many different other common side effects. We also have tocilizumab. This is available both as intravenous infusion as well as sub-Q injection that the patient can administer at home. It is not recommended to be initiated in patients that have an absolute neutrophil count less than 2,000, platelets less than 100,000, or having a AST or ALT level that is greater than 1.5 times the upper limit of normal. And a serious side effect associated with tocilizumab is the myelinating CNS disease. This is very similar to our TNF-alpha inhibitors, as well as GI perforation. GI perforation is seen more so in patients that have additional risk factors, which include history of diverticulitis, being of older age, concomitant glucocorticoid or NSAID use. Common side effects with this drug include hyperlipidemia, constipation, and hypertension. And then our last non-TNF-alpha inhibitor is sarilumab. This is a subcutaneous injection, and it has the same cutoffs that tocilizumab does. It is, well, almost the same. So patients that have an absolute neutrophil count less than 2,000, a platelet count of 150,000, so this is what's slightly different. It's 150,000 as opposed to 100,000, or an AST or ALT level that is greater than 1.5 times upper limit of normal, would disqualify a patient from using sarilumab. Serious side effects are similar to tocilizumab. Patients rarely can develop GI perforations, and then common adverse effects include hyperlipidemia, increases in LFTs, neutropenia, and antibody development. We'll take some time going over TNF-alpha inhibitors, which include infliximab, etanercept, adalimumab, golimumab, and certolizumab pegol. The most common adverse effects associated with TNF-alpha inhibitors, especially those that are sub-Q injections, include injection site reactions. Patients can experience pain, redness, itching, bruising, swelling, or irritation of the injection site. Infliximab is an intravenous medication, and it has to be administered with acetaminophen and a antihistamine at least 90 minutes before the infliximab infusion to minimize acute and delayed infusion reactions. TNF-alpha inhibitors are also associated with several rare but very serious adverse effects. These include increased risk for infections, including bacterial, fungal, and viral infections, which is why patients must be screened for latent TB prior to initiation of the drug. Patients can also have new or worsening demyelinating disease. So studies show that patients develop new MS or worsening of their already existing MS, or development of new onset Guillain-Barré syndrome. Patients can also have worsening or new onset heart failure, and the same warning actually is included in all the TNF-alpha inhibitors. Patients can also experience pulmonary fibrosis or pulmonary interstitial lung disease. Patients with underlying lung disease or using concomitant methotrexate with a biologic are actually at an increased risk for pulmonary fibrosis compared to patients that don't have any pulmonary disease at baseline or are not combining their biologic with methotrexate. These medications also have a risk for malignancy. Studies show that patients taking TNF-alpha inhibitors may have an increased risk of lymphomas and lung cancer in particular. However, it's difficult to establish a definite correlation because we also know that patients with rheumatoid arthritis, just based on the disease pathophysiology, are at a slightly increased risk of developing cancer compared to the general population. And then finally, patients that are taking TNF-alpha inhibitors may also form what is called a drug-neutralizing anti-drug antibody. These antibodies bind to the medication, the biologic that the patient is taking, rendering the medication ineffective in patients. And the TNF-alpha inhibitors that are most commonly associated with drug-neutralizing anti-drug antibodies are infliximab and adalimumab, as well as its biosimilars. We also have our non-TNF-alpha inhibitors, which include abatacept, which is a T-cell co-stimulation inhibitor. We have rituximab, which is a CD20 inhibitor, and we have two additional monoclonal antibodies, tocilizumab and sarilumab, which are interleukin-6 inhibitors. For this umbrella of medications called non-TNF-alpha inhibitors, it is recommended to still screen for latent TB as well as hepatitis prior to initiation. For abatacept, which is available both intravenously and as a sub-Q injection, Caution should be used in patients that have baseline COPD, as there are reports that this medication can cause COPD exacerbations. Also, this medication is associated with skin cancer, so periodic skin exams are recommended in case the patient does develop malignancy while they're on abatacept. We also have IV rituximab. This medication must be pre-medicated with acetaminophen, antihistamine, and methylprednisolone, 100 milligrams IV, 30 minutes before infusion, because it is associated with many infusion reactions. Rituximab is recommended really for patients who are not at goal despite maximally tolerated methotrexate and inadequate response to another TNF-alpha inhibitor. The reason why this is not one of the preferred biologics is because of the many serious side effects associated with it, not only infusion reactions, but also progressive multifocal leukoencephalopathy, severe mucocutaneous reactions, severe infusion reactions that can occur with rituximab. Some common side effects with this drug include flushing, hypertension, peripheral edema, rash, weight gain, abdominal pain, antibody development, and many different other common side effects. We also have tocilizumab. This is available both as intravenous infusion as well as sub-Q injection that the patient can administer at home. It is not recommended to be initiated in patients that have an absolute neutrophil count less than 2,000, platelets less than 100,000, or having a AST or ALT level that is greater than 1.5 times the upper limit of normal. And a serious side effect associated with tocilizumab is demyelinating CNS disease. This is very similar to our TNF-alpha inhibitors, as well as GI perforation. GI perforation is seen more so in patients that have additional risk factors, which include history of diverticulitis, being of older age, concomitant glucocorticoid or NSAID use. Common side effects with this drug include hyperlipidemia, constipation, and hypertension. And then our last non-TNF-alpha inhibitor is sirolimus. This is a subcutaneous injection, and it has the same cutoffs that tocilizumab does. It is, almost the same. So patients that have an absolute neutrophil count less than 2,000, a platelet count of 150,000, so this is what's slightly different. It's 150,000 as opposed to 100,000, or an AST or ALT level that is greater than 1.5 times upper limit of normal, would disqualify a patient from using sirolimus. Serious side effects are similar to tocilizumab. Patients rarely can develop GI perforations, and then common adverse effects include hyperlipidemia, increases in LFTs, neutropenia, and antibody development. This was a large cohort study of greater than 60,000 patients conducted by Barbulescu and colleagues in Sweden. It looked at the rate of gastrointestinal perforation in patients that have rheumatoid arthritis that are treated with various biologics. And it showed that after adjusting for glucocorticoid use, the risk of GI perforation was much higher in the tocilizumab arm compared to that of other biologics, including TNF-alpha inhibitors, abatacept, and rituximab. So this is our first assessment question. Which TNF-alpha inhibitor is most associated with the development of drug-neutralizing anti-drug antibodies causing treatment failure? Letter A, certolizumab. Letter B, golimumab. Letter C, etanercept. Letter D, adalimumab. And our correct answer here is adalimumab. As I mentioned earlier, adalimumab and infliximab are the two TNF-alpha inhibitors that are most associated with the development of drug-neutralizing anti-drug antibodies. Remember, these antibodies bind to the drug and prevent it from working, which you will see in this patient as worsening of symptoms and worsening of disease activity. Our final group of medications are our Janus kinase inhibitors, or JAK inhibitors. This is what we refer to as the targeted synthetic DMARDs. These medications include tofacitinib, baricitinib, and upadacitinib. It's important to note that these medications cannot be combined with biologics. They can only be combined with our conventional synthetic DMARDs. They do carry a black box warning for serious infections, thrombosis, major adverse cardiovascular events, and malignancies. It is recommended that patients get a CBC prior to initiating JAK inhibitors because we want to ensure that their ANC is above 1,000, lymphocytes are above 500, and hemoglobin is above 8 at baseline. These should be monitored while the patient is on therapy to make sure that it doesn't dip below those numbers. If the hemoglobin decreases by greater than 2 grams per deciliter, it is recommended to discontinue the medication at least until the hemoglobin levels go back to where it was at baseline or within normal limits. Some common side effects of these medications include hyperlipidemia, infection, including reactivation of the hepatitis B virus if the patient had hep B at baseline, nasopharyngitis, as well as hypertension. Some serious but rare side effects include GI perforation and hepatotoxicity. So monitoring, as I mentioned earlier, recommended to monitor neutrophils, platelets, and hemoglobin at baseline 4 to 8 weeks, at the 4 to 8 week mark, followed by every 3 months thereafter. Tofacitinib and upadacitinib are both major substrates for CYP3A4, so it's important to be cognizant of drug interactions when using these JAK inhibitors. This study, conducted by Eatonberg and colleagues, investigated the relationship between tofacitinib and cardiovascular events, as well as cancer risk in patients with rheumatoid arthritis. They randomized patients to receive either tofacitinib 5 milligrams BID, tofacitinib 10 milligrams BID, as well as TNF-alpha inhibitors, with the primary endpoint of major cardiovascular events and cancers, and a median follow-up time period of 4 years. And they saw in the study that the incidence of cardiovascular events and cancer were higher in the tofacitinib arms, both the 5 milligram and 10 milligrams, compared to TNF-alpha inhibitors, which warranted the FDA to require manufacturers of tofacitinib, baricitinib, and upadacitinib to update their package insert with the warning for cardiovascular events, which was not in the package insert in the past. Our next assessment question is SP, who is a 32-year-old female patient newly diagnosed with RA of both knees. She complains of painful and swollen joints and morning stiffness that lasts more than 1 hour. Her rheumatologist decides she has moderate disease activity with an SCAI score of 12. Her labs show elevated ESR and CRP, but her CBC and CMP are within normal limits. She has no relevant past medical history, is not taking any medications. Which of the following is the best treatment for SP? Answer choices are tofacitinib, hydroxychloroquine, methotrexate, and etanercept. And the correct answer here is methotrexate is our first-line regimen for patients that are treatment naive, or rather DMARD naive, with moderate to high disease activity at baseline. Vaccinations are important. We want all patients to be up to date on their immunizations, but for patients with RA, this is especially important because DMARDs can have, depending on the vaccine, whether it's live or inactivated, it can have some risk of side effects to the patient. So for live vaccines, which are contraindicated with DMARDs, it has to be administered at least 4 weeks prior to initiating a DMARD. And for inactivated vaccines, it's recommended that they are administered at least 2 weeks prior to initiating DMARDs. And the reason for that is because administering live vaccines when a patient is on a DMARD might diminish the therapeutic effect of the vaccine, which is why we want to give patients adequate time to mount immunity in those 2 weeks prior to initiating a DMARD. Live vaccines are contraindicated for the reason that it can potentiate an infection in patients who are using DMARDs. So once a patient is on a DMARD, we want to make sure that they are receiving the efficacy that we intended them to receive from the medication. So what we're going to monitor for is really clinical signs and symptoms of RA. Patients should see a decrease in morning stiffness, longer time to onset of afternoon fatigue, reduction in joint swelling, decreased warmth of the skin, decreased tenderness in the joints, reduction in joint pain, improvement in performance of activities of daily living, and radiographic images should not show any signs of progression of disease. And then in terms of lab monitoring, we expect to see a normalization of our acute inflammatory reactants such as ESR and CRP. In conclusion, RA is a chronic autoimmune disease causing inflammation of synovial joints symmetrically. DMARDs are used to treat RA, and the selection of DMARD really is dependent on whether the patient is treatment naive or rather DMARD naive or DMARD experienced, and what level of disease activity they have. Patients that are DMARD naive who have low disease activity, hydroxychloroquine is going to be first line. For patients that have moderate to high disease activity, methotrexate will be first line. Untreated or undertreated RA will lead patients to develop deformity of the affected joints and disability, which is why it's really important that patients receive treatment as soon as they're diagnosed. And for patients that are biologic or TS-DMARD naive, a treat-to-target approach can be utilized in those patients. A dose reduction in their methotrexate or hydroxychloroquine can be utilized as long as the patient remains at low disease activity or remission for at least 6 months. And finally, patients should be up to date on their vaccination prior to initiating DMARDs to make sure that we are providing adequate prevention for patients, especially since a lot of the DMARDs do increase risk for infection. So we want to utilize as many preventative measures that we have available to us prior to the patient initiating a DMARD. These are my references. Thank you for listening, and let me know if you have any questions.
Thank you all for participating in today's live webinar. If you haven't already, please go ahead and enter your questions or comments into the chat box now, and we will do our best to answer as many questions as possible in the remaining time available. To receive course credit for reporting to CE Broker and CPE Monitor, please take note of the 4-digit attendant confirmation code. If you are accessing this webinar from AchieveCE.com, you will need to log in and access it from your user dashboard under My Live Webinars. If you're accessing this course directly from cebroker.com, you can find this course under My Learning. On both platforms, click Next on the bottom right of the screen and enter the 4-digit code to receive credit. We hope you've enjoyed this latest live webinar and look forward to seeing you soon.
Good evening, everyone. Thank you for listening to tonight's webinar. Please enter your questions in the chat box or the Q&A box on the bottom, and I'll try to go through as many questions as I can this evening in the remaining time we have left. There are no questions coming in currently. I'll give it a couple more minutes before we close the session for tonight. Okay, I don't have any questions coming in. So thank you for the remaining bunch that are still here. Thank you for listening.
and hope to see you guys in another webinar.